as part of your general medicine slash community based medicine, hypertension is really important to have an understanding of. It's our 1A, 1B conditions on the matrix. So this presentation is going to be looking at essential hypertension, secondary hypertension only very, very briefly, and then malignant hypertension, again only very briefly. And then we'll have a look at the management, particularly in terms of general practice. So a quick overview. The ideal blood pressure, so to be in a normotensive state, is considered to be 120 systolic over 80 diastolic. To be in a hypotensive state, the blood pressure is around 90 over 60, and then we're considered hypertensive when our blood pressure is above 140 over 90. Now, it is really important to remember that blood pressure will vary from person to person. Very, very small, thin, slight individuals may have a lower blood pressure at baseline than that of somebody who is a larger individual, and everyone is different, so it's really, really important to bear that in mind in any presentation. Somebody who sits with a blood pressure normally at 120 over 80, if their blood pressure was to drop to 90 over 60, then yes, you would classify that as hypotensive. Whereas if somebody's normal blood pressure is 95 over 65, then for them, being hypotensive may mean sitting at 70 over 50 or 70 over 40. So no one blood pressure for one person will ever be the same. So hypertension can be classified into stage 1 hypertension, stage 2 hypertension, and severe hypertension. So stage 1 is when your blood pressure in surgery or clinic is anything above 140 over 90. Stage 2 is when your blood pressure in clinic is anything above 160 over 100, and severe is anything over 180 over 110. Now, the reason that I include the ambulatory and the home figures underneath this is because we know that white coat hypertension or white coat syndrome does exist, and it's a phenomenon where people exhibit a blood pressure level above what their normal range would be in a clinical setting that they wouldn't exhibit when they were at home. So it might be that you have somebody you might not expect to have a high blood pressure sat in front of you scoring 150 over 70, but actually when they're at home their blood pressure is regular. Hence why, unless the reading is exceptionally high, that we would give people home blood pressure kits to go away and monitor their own blood pressure to give us a more accurate reading. And as you can see, there's a slightly lower threshold with your ambulatory or your home blood pressure monitoring than there is in the surgery. So when we're using the ambulatory blood pressure monitoring to confirm a diagnosis of hypertension, you want to make sure that there are at least 2 measurements per hour that are taken between the person's usual waking hours. So that's between, I don't know, for me that would be between 7 o'clock and 10 o'clock at night. And then you would use the average value of at least 14 measurements taken during the person's usual waking hours to confirm that high blood pressure. But when you're using home blood pressure monitoring to confirm a diagnosis, so you need to ensure that for each blood pressure recording that 2 consecutive measurements are taken at least 1 minute apart and with the person seated, and you need to make sure that the blood pressure is recorded twice daily, ideally in the morning and the evening, and that blood pressure recordings continue for at least 4 days and ideally for 7 days if you can. So the ambulatory blood pressure monitoring is the one that you wear on your arm that pumps itself up and records the readings for you. The home blood pressure, and some people don't tolerate the ambulatory blood pressure monitoring very well, whereas the home blood pressure monitoring, the individual might go out and buy their own blood pressure cuff and do that themselves. You're supposed to disregard the measurements that are taken on the first day and then use the average value of all the remaining measurements to confirm your diagnosis. If we're moving into severe hypertension, then ideally you want to be referring a person to specialist care. If they have high blood pressure if they have a blood pressure of 180 over 110 with any signs of papillary edema or retinal hemorrhage, or if you're suspecting pheochromocytoma, so that person may have a headache, palpitations, your review of systems will be really important if you're taking a history. So, malignant hypertension, so this is a medical emergency. So this is a syndrome characterised by severe hypertension when the systolic is above 200 and the diastolic is above 130. And if it's accompanied by end organ damage, for example, encephalopathy, pulmonary edema, nephropathy, papillary edema. And the symptoms you might get with that are headache, seizures, visual disturbances, nausea and vomiting. The aim here is to reduce the blood pressure as early as possible. These are the people that you want to be referring into secondary care, into acute care straight away, because if this goes untreated, there's only a 10% 1-year survival rate. So a complication associated with the malignant hypertension, 9 out of 10 people will die within a year if this blood pressure isn't brought down. Generally, IV antihypertensive treatment will help bring that blood pressure down. But again, you need to observe for a period after the treatment's been given to ensure a stable blood pressure is kept. So your clinical approach to hypertension. So unless you're sitting in that severe category, it's usually asymptomatic. You want to ensure thorough history taking. So have they had any symptoms? Because if they do, that's important. And they may have high blood pressure and not know about it. Any medications they take. So are there any blood pressures that could be potentially worsening this hypertension? Or is there anything that we can give them to help bring it down? And risk factors. Are they diabetic? Are they overweight? Is there a family history? Do they have a poor diet? They're all things to worry about. We talked about the BP monitoring, so that can be the home blood pressure or the ambulatory kit. 12-lead ECG might be helpful, particularly if these people are having chest pain. Urine dips looking at renal function, and again, your User-Knees will help that in terms of your blood work. An echo, because this will help create a bigger picture. Often elderly people with hypertension have other issues with their heart and have some degree of failure of the heart. And again, testing for secondary causes, so pheochromocytomas. So 2 slides on the management of hypertension. First and foremost, the one we always try and go for first, lifestyle interventions. That should always be offered initially unless the individual is falling into that stage 2 hypertension. And then periodically after the lifestyle interventions you've been counselling your patient on those, then blood pressure should be checked fairly regularly. You would do this in the history, but ascertaining people's diet and exercise patterns are helpful, and then you can help guide their choices to bring that blood pressure down. So antihypertensive drug treatment should be offered to anyone under the 80 years with stage 1 hypertension, particularly if they've got target end organ damage, they've got established cardiovascular disease, renal disease, diabetes, or their 10-year cardiovascular risk is equivalent to or greater than 20%. And then anyone with stage 2 hypertension should be offered therapeutic management. This is just a very brief breakdown from the NICE guidelines of the treatment options. So if you're under 55 years old, then your step 1 would be an ACE inhibitor or an angiotensin II receptor blocker, an ARB, in comparison to if you're over the age of 55 or a black person of African Caribbean family origin of any age, then you'd be looking to give a calcium channel blocker as your first line. But then after that, the steps mimic one another. So step 2, 3, and 4. So after step 1, step 2, 3, and 4 mimic one another for the remaining treatment options.